The results are in. The favorite type of lips are perfectly proportioned. Perfectly proportioned means balance between the volume in the upper and lower lip, and perfect symmetry on the left and right. Your second favorite was lips with voluptuous volume. Lips with voluptuous volume are full lips with a plump pout. Lips with a defined and prominent lip border. Coming in at number 3 is definitely defined. The full list is available in clinic, or ask your clinician and they will explain the features and the differences. Over time, our lips change. They become thinner with age and begin to flatten, and vertical lines emerge from regular lip movement. Dermal fillers are a treatment designed to enhance or restore volume. Made from naturally occurring complex sugar, the injectable gel treatments fill in and plump up your lips. Talk to your clinician about enhancing or rejuvenating your lips.
For ethnic rhinoplasties, after we've done the cephalic trim, the Collier-Miller strut with the tip suturing, usually we're going to need still to add something more to give it more projection and definition. So this little blue thing is a template for a piece of cartilage, and this is called a shield graft that we're going to put to add more projection and support and strength to the tip of the nose. So we're going to use this as a template for the cartilage. Okay, so we're going to carve out a piece of cartilage from this little template. We're going to use this mallet. So let's see if we have our little template. Okay, so here's our template, and now I'm going to carve this. This is nice and thin, feels very, very good. Now what we need to do is place this piece of cartilage, called a shield graft, on top of the existing cartilage. And that one piece of cartilage is very important to giving the nose that nice look, making it appear thinner, especially when it's very bulky and have thick skin. And this will hopefully finish everything beautifully. But what's really important to that is we have to put cartilage alongside the shield graft so that it will look nice and balanced from the side of the nose. I just want to see what this looks like. You can't just have a piece of cartilage sticking up like that. It will look great in the beginning, but later on as time goes on, you'll start seeing the actual edge of the graft and it'll become very noticeable and the patient will not be happy. So what we now need to do is we have to soften the transition around both sides so that it will look very natural. I need the other cartilage, please. So this graft is a combination of what we call a lateral quill strut graft and an anal rim graft. Rim grafts are used in many of my rhinoplasties. The reason why we use rim grafts is because they can help the nostrils and the support of the nostrils in many ways. These are small pieces of cartilage that will help stabilize the existing nasal cartilage so that it won't collapse, and soften the transition around the nose, and also keep her nasal airway nice and patent or open as the years pass. So now at this point we've completed building up the tip, and now we have our tip projection, and after I've completed my tip projection, now I'll move to augmenting the dorsum. When we went in for Erica's surgery, we had numerous procedures we had to do. So we just finished seeing Erica at 6 weeks following her rhinoplasty surgery. As you can tell by looking at the before and after photos, her nose looks a lot better, and she still has a lot more healing to go. So I'm very happy for her right now.
Hi, this is Kristen. I'm Dr. Michael Schwartz, and we are doing a few things today. Kristen thinks she looks tired, and that, I believe, is mostly her lower lids. And interestingly, follow this Q-tip. We'll start with this and just look up. When you look up, it forces the fat in the lower lids out. She doesn't really have a lot of fat in her lower lids, so you can just look straight ahead. Just slight puffiness here, but what makes her look tired is the fact that her cheek has descended a little bit here. She has a trough here. She has some prominence here, which is thought to be orbicularis muscle, or the muscle that encircles the eye, or just soft tissue. It's hard to know. But we are going to lift the cheek through the lower lid and also up under the lip, and also through a small incision here. And so we're going to elevate this area, including her cheek, and reposition it more superiorly in order to support her lower lid, to give her less rounding here. Also, she has somewhat prominent eyes, so we're going to give better support to the lower lid so it doesn't pull down. And also we're going to trim a little skin from the upper lid. Again, I like to take that up and out here. It ends in one line that goes superiorly as it goes laterally. And close your eyes, please, for a minute. And we want her to be able to easily close her eyes, but this will end up in a line that goes like this. And here the extra skin is about this much. And then we're also going to do a rhinoplasty. Kristen doesn't like this crevice in the middle of her nose, which is formed from a depression between the two cartilages that make up the tip. They're called the lower lateral cartilages. I've outlined them here. And you can see the face forms in vertical halves. It's normal to be asymmetric, and her left lower lateral cartilage is much larger than the right. It's stronger, it's very convex. The lower edge is right here, the upper edge is here. It can be felt by pushing on the lower edge and also visualizing the upper edge. And so I'm going to remove, actually, a portion of the lower lateral cartilage here will be removed. And I'm also going to take out a little rectangle here, maybe not that big, put a little stitch from here to here and here to here in order to decrease the convexity of her cartilage and make it a little narrower and more refined without altering this. We're also going to put a stitch between what are called the domes of the tip of her nose in order to get rid of the crease here. I've marked some landmarks here. This is the course of the frontal branch of the facial nerve that elevates the eyebrows. Elevate your eyebrows for me. And hopefully she'll be able to do that after surgery. And this is the incision we're going to go through to elevate this here. Will be hidden behind the hair. I'm going to just leave this here as a reminder to me, which is it's always above the field of the surgery, so we're not really in the vicinity of this in terms of surgical planes, but it does go through the field. Okay.
Amalia is our patient today. She is 54 years old, and she is interested in a very popular procedure, hand rejuvenation. I find that many patients have become interested in this procedure. They come to see me for facial rejuvenation and for other procedures, and then they say, "Doctor, what about my hands?" And so today we're going to demonstrate a very straightforward procedure, and we'll use a state-of-the-art filler, Radius calcium hydroxyapatite. Typically, when we're evaluating a patient for aging hands, we want to look for two things. And the first thing we look for are aging spots, and these are usually discolorations that we can see on the dorsal surface of the hands. And Amalia shows some of the early changes of aging. We do have some hyperpigmentation in some areas, but this is not the predominant feature that we see. For these types of things, we usually use a pulse-dye laser, and that can take the color out. The most important thing that we look for in all patients is loss of volume. Usually patients will tell me that they don't like the vein show, they don't like to see the tendons and the fine anatomy of the hands, and they want fuller hands that suggest a more youthful appearance. So today what we're going to do is use Radius and a nice carrier, and we'll use that to add some volume to her hands. Now what I've already done, Amalia, is I've just added a little bit of numbing medication, and we're just mixing that with a little bit of numbing medication so you can have a nice comfortable treatment. So what we'll start off by doing is adding a little bit of the product in just a little volume, a bolus, and I'm going to tint the skin just a little bit, and we'll introduce the needle like so. 1, 2, 3. Here's a beauty ouch. Beautiful. And then we're just going to very, very gently add a little bit of the product. And you can see the product being added in the subcutaneous space. And can you feel that, Amalia?
No, not at all.
Good. And as you see, this is very well tolerated. And patients are quite surprised. There's really very little pain associated with the procedure. Now, once we've added the product, we now want to mold it. And so we just begin to mold the product into place. Patients want to come in, they want something quick, and they want to see it. And that's precisely what this product allows patients to do. How do you feel?
Okay.
How was that? Did you feel it at all?
Not at all.
Great. This product creates a natural scaffolding within the soft tissues and allows Amalia's own tissues to grow and to sustain the volume. And you can even see it as I'm moving it throughout. Soft tissues here. Do you feel anything at all? Wonderful.
Little pressure
Right.
from your hand.
Okay, let's flatten you back out. Very, very good. And you see, with essentially no pain, we've got a nice correction. And, you know, it's normal to see some evidence of the normal hand anatomy, but I'm very happy. It's a very natural look. She may have a little bit of redness, maybe some swelling. After the procedure, we like to have Amalia avoid things that can exacerbate bruising, which would be aspirin, Motrin, Aleve, and so forth. We'll probably see her back in a week, and in a week's time, we'll take a look and see if she's happy, if there are other areas that we need to correct. If so, we can add a little touch-up. And then I usually have her come back in about 3 months or so. And at 3 months, again, if we need to do a small touch-up, we'll do so. And that really, I've found, helps to extend the longevity of the product till about 1.5 years or so, which is what we're aiming to do. We've just treated Amalia's right hand, and we've not treated the contralateral left side. And on the left side, as we saw on the untreated right side, we still see more veiny prominence. There's evidence of tendons and so forth. The skin's a little wrinkled and crepey. And so I hope that demonstrates very nicely the contrast between an untreated left hand with some of the architecture quite visible and a little bit more soft tissue cover, if you will, over the treated right hand.
We perform the mid-face lift by using silhouette sutures. In this case, we are going to use 4 silhouette sutures, the first 2 sutures in a rather horizontal direction and the second ones in a more vertical direction. The first 2 sutures will be placed in the more lateral portion of the temporal incision, while the second 2 in the more medial part of the same incision. We start with an incision in the temporal region, then we lift the margins of the wound with 2 hooks and we identify the deep temporal fascia. Once the deep temporal fascia is exposed, we make a moderate undermining with a smooth instrument to have enough space to place a polypropylene patch of 2 by 1 centimeters. We place this polypropylene patch to the deep temporal fascia in order to have stronger tissue to enable better resistance to the tension caused by the sutures. The patch is stitched to the fascia using a Vicryl 4/0 to avoid movements of the patch during the placement of the sutures. We'll see now how to place the sutures. First we insert the sharp end of the straight needle into the temporal incision in a parallel direction superficial to the deep temporal fascia. At the temporal hairline level, we pass through the temporoparietal superficial fascia. In this way we move from a deep to a more superficial plane, so that the suture now runs in the subcutaneous tissue. To make sure that we are in the correct plane, we put gentle pressure with our hand on the posterior part of the straight needle, so that we lift the sharp edge of the needle towards the derma. Then with horizontal movements, we should be able to see the end of the needle easily moving in the subcutaneous tissue. If we are not able to see the end of the straight needle, this means we still are in too deep a plane, while if we can see the end of the needle but we cannot move it, this means we prick the derma and we are too superficial. Once we are sure that we are in the correct plane, we keep on inserting the trocar as far as the pre-planned point of exit on the skin. So we have a deep plane where we introduce the straight needle and a superficial plane through which the sutures run to lift the tissues. The straight needle is moved through the subcutaneous tissue, trying to keep the end of the needle at the same depth, pushing the trocar by hand, especially at the bigger point of the curvature of the face. Then we arrive at the exit point and we pass through the skin. We pull out the straight needle so that the suture will be in the right position. When all of the straight needle is pulled out, we pull the suture until the first knot comes out of the skin. This knot stops the first cone, so we have to preserve this knot by cutting the suture distally to it. Now we can check the traction that the first suture makes on all the malar region. Then with the curved needle we pass through the deep temporal fascia just in front of the patch, and we come out through it. Afterwards we remove the curved needle and we place a clemar to stop the suture. Now we will see how to place the suture using an instrument with a smooth end. We insert the smooth end needle in the trocar and then we use the instrument as we did before with the straight needle of the suture. Now we are in the deep plane, and when we arrive at the hairline we pass through the temporoparietal superficial fascia. We will meet more resistance because of the smooth end. We make sure we are in the correct plane and we move the instrument in the direction of the exit point. The smooth end of the instrument is not able to pass through the skin, so after we arrive at the exit point, we remove the smooth end needle from the instrument and replace it with the straight needle of the suture to pass through the skin. Then we pass through the skin, we pull out the trocar, and then we pull out all of the straight needle. When the first knot comes out, we know that all of the suture has been inserted. Then we make sure that the distance between the exit point on the skin and the hairline, when we change plane of dissection, is more than 9 centimeters. The first 2 sutures we have already placed have an effect on the nasolabial fold, on the projection of the malar area, and on the largeness of the region of the lower eyelid. Now we will insert the other 2 sutures. We use the smooth end instrument because, as I've said before, it is a safer instrument to avoid damage to the vascular structures in a region when we change our plane of dissection. The change of plane at the level of the temporal hairline is very important because it avoids causing damage to the temporal branch of the facial nerve as we place the sutures superficially to the plane where the nerve runs. We push the smooth instrument towards the exit point number 3. Then again we remove the smooth needle from the instrument and we introduce the sharp-ended needle of the suture to pass through the skin. We remove the trocar, we pull the suture until the first knot comes out, and we cut the suture distally to the first knot. Then we verify the mobilization of the soft tissue made by the suture.
This is Dr. Art Foley, and thank you for visiting us on our website. This is a breast lift operation which was done in our office. The patient is now 1 month following surgery. You can see the scars are still a little bit apparent, and they will fade considerably with the passage of time. The breast lift operation involves making the skin of the breast envelope, the skin envelope smaller. What I do is I draw all the key markings out prior to surgery with the patient in a sitting position. This allows me to see exactly where I want to place the nipple areolar complex and ensures that we have good balance and symmetry with the patient's ultimate appearance following surgery. I'm making the key markings where I want to lift the nipple areolar complex. Nothing is detached with this operation. The sensation remains the same. I'm just making the skin envelope smaller to make the breast more youthful, more perky. You can see there I'm just checking my marks there where I want to remove some skin underneath the breast to make the breast actually a tighter envelope. The small circular line above the breast on the superior portion of the breast is where the nipple areolar complex is going to go, and now you can see how those skin flaps come together and create a higher position for the nipple and areola. We do these operations in the office under general anesthetic. There's our nurse anesthetist with a full complement of equipment. What I'm doing now is I'm just checking out the markings which I previously made. The patient's asleep at this time, and I want to mark out the smaller diameter of the nipple-areolar complex, and I use that little metallic ring marker to mark out the smaller diameter. I'm just demonstrating now how the skin is going to come together and checking everything. These marks that I made before surgery are highlighted with a little blade. Nothing is detached. I do want to remove the outer skin layer on the areas of the breast that are going to be inverted. What I've done now is just mark out the areolar area, the smaller diameter. Since the breast is going to be actually smaller, and here I'm marking out the left breast, I want to make sure that the areola is of appropriate size. And so what I do is I mark that out and then highlight that with a little blade. Now all the skin that needs to be inverted or invaginated has to have the outer skin layer removed. So the only thing that's removed during this operation is just the outer layer of the skin. That way there's no change in sensation for the patient following surgery. Now once I removed all the outer skin layer, I am able to slide the nipple-areolar complex up into its newer, higher location. The small area of extra skin on the side of the breast on either side underneath the breast is actually removed, and then there's one stitch that brings everything together. I leave that stitch in for approximately 10 days. That's the only suture that needs to be removed. Now I'm bringing the skin flaps together, and you can see already the breast looks tighter. Temporarily I've put a few staples in the skin just to bring the skin edges together prior to putting the stitches in. All the staples are removed before the end of the operation. This allows me to check to make sure that the breasts are very symmetrical. Now I'm putting the stitches in, and these are all dissolving sutures. There's only one suture actually that's removed, and that I placed at that inferior part of the incision. So all these stitches are actually underneath the skin. This ensures that we have the best looking scar possible. This operation normally takes about an hour and a half to do, and you can see I'm putting in the dissolving sutures underneath the breast, and the breast already has a much more youthful, perky shape. We've made the skin envelope tighter and smaller to give the breast more projection and lifted the nipple-areolar complex to a higher position. This is almost like a living bra. When the surgery is completed, little sticky tapes are placed, or stereo strips are placed along the incision lines, and we usually leave these in place for 2 to 3 weeks. This helps to minimize the amount of redness in the scar and certainly helps the healing process. There's only one suture that's actually removed, and that's just at that junction of the inverted T incision at the base of the breast, and I usually remove that suture in about 10 days. Patients don't have a lot of discomfort with this operation, although the breasts are a little bit sore, because it's basically a skin operation. Here's the patient before and after surgery. She's only 1 month after surgery, so the incisions are still a little bit red, as one would expect. And thank you very much for viewing this video.
Let me tell you how we do sizing. I think you want to look good 2 ways. One is in your clothing and one is with your clothing off. So what we'll have you do a week or 2 before surgery, my nurse will put a bra on you and a t-shirt and pads in there until you fill your blouse out an amount that to you looks good. I'll then get a scientific notation telling me exactly how much bulk you want there. And then I'll want you to bring in a picture or pick one of our pictures of a naked chest, so I have an idea of what you think is proportional. At the time of surgery, we'll do the surgery, and I'll put a temporary sizer in there and inflate it to the size that we think we want. Compare the way you look to the picture, adjust up or down a little bit, and then I take the temporary sizer out and put the permanent implant in. Basically, an implant is a shell filled with something. A saltwater implant, that shell is filled with a solution of salt water. A silicone gel implant is a more complicated shell, but it's filled with a mixture of gelatinous silicone. We have the new cohesive gel implant. This is under clinical trial. The advantage is it has shape, and as you can feel, it is firmer, so it's more youthful, and it has shape. Like most women, your breasts are not absolutely identical, but you're close enough that we'll put the same type and size implant in. Now, for the silicone gel implant and the saltwater implant, we go through just right the edge of the areola. That hides the scar really well. The cohesive gel implant is stiff enough, I have to do a little 2-inch incision right at the fold of the breast. So those are the 2 incisions that we use. The other choice is to do it endoscopically. Then what we do is make a short incision in one of the natural folds in the armpit, and we can put a saline implant in through that incision, and then there's no scars at all on your breast. After surgery, you'll have this big bulky dressing on. The next day, we'll take all of that off. You'll have a much lighter dressing and a surgical bra on. We use a device called a pain pump. It's a reservoir with long-acting local anesthetic and 2 tiny little catheters about the size of a paperclip wire. One goes in here, one here, and it numbs your breast so that you're much, much more comfortable after surgery. 3 days after surgery, you just pull those out yourself. Your skin's numb, so you hardly feel it coming out.
Hello, my name's Adrian Richards. I'm a plastic surgeon and the surgical director of Aurora Clinics, which is based here in the United Kingdom. Today I'm going to be talking you through an operation I did recently on this lady who had breast implants inserted in front of the muscle and which had gone hard, particularly on the right side. So she had some discomfort and some distortion on that side. As you can see, the implants pulled in. Here I am moving it, and you can see it's quite tight, not moving very well, and not very compressible. So the first stage of the operation is to remove the old scar. And here I've just drawn around it, and here I'm just taking the old scar tissue out. So I don't want to leave 2 scars, I just want to leave 1 scar, hence the reason for removing that scar. The next stage following removal of the scar is really to identify the implant, and in this procedure I'm going to perform a total capsulectomy. So here I am with the cutting diathermy just dividing through the tissue. That's the outline of the implant, and I gently dissect around it, removing the whole capsule, which I'll show you in a minute, around the implant. And this needs to be done sort of quite gradually with the electrocautery. So I've removed the implant, and that is with the surrounding capsule, which is holding it very tight. And I'm going to show you in a minute the capsule being removed. Here I am dividing the capsule, and as you'll see, the implant will sort of spring out, so the capsules really pull the implant tight. Actually, the implant, you can see, had a small hole in it inside. But as I'm releasing the capsule, can you see how the implant really wants to get out? And that's why the implant feels so hard when it's inside the body. Here I'm just demonstrating that the whole of the capsule is removed, and this is the capsule around the implant, which has made it go high, and you can see how much smaller than the implant it is, and hence the reason why the breast has gone firm. The next stage is really, once I've cleaned everything out, to insert an operative sizer, and this is a temporary inflatable implant which I place inside the breast cavity, and then I can inflate it slowly with a syringe of saline. So in this case I inflated it, and I found the optimum fill volume of the breast slightly larger than the 290cc implants that were removed with the capsule, so I replaced them with 325cc implants. But I like this technique because it just gives me a bit of flexibility on the size of the implant, and enables me to fill the cavity adequately. Here I am just checking that no bleeding blood vessels. Very careful to do that. And the next stage is to insert a breast implant. And you can see I've put betadine, which is the brown material on the skin. I've put antibiotics inside the cavity to reduce any risk of infection, and then the breast implant is inserted, and everything's ensured that it's just lying flat against the chest. So this picture just shows before. You see a hard, immobile implant, and this is after the finish of the operation, much more mobile and soft. So thank you for watching this video. I hope it's been informative and has shown you what a capsule looks like. If you'd like any information about this form of surgery, any other form of breast surgery, or indeed any type of cosmetic or plastic surgery, please contact us.
So today we're going to talk about post-liposuction rolling. And this is a small roller, and this is the big daddy. This is a big roller. And this is what we're going to use after liposuction in order to help contour the skin. We're basically going to roll these objects on top of the body in order to make sure that the skin is as smooth as possible. It stimulates the skin, it makes the fat layer even, helps the skin to retract, and it's real important. We usually start this about 2 weeks after your procedure. In the case we're talking about today, I did a almost 4,500 cc liposuction. That's a pretty big liposuction. The typical areas are the abdominal, the mid to upper back, posterolateral flanks here, maybe the thighs, upper medial legs. So these are all the areas that we're going to talk about treating these with rollers today. Okay, this willing patient is about 3 weeks after a liposuction, and remarkably, she has no bruising, which is pretty impressive. That's probably because of the Arnica and the Bromoline that we use. But the areas that we treated was her entire abdominal region, her upper medial thighs, turn around, and this whole area right through here. So that's the predominant area. We didn't do anything back through here because we thought she's great and she's got a great tuchus, so we're all good here. But you can see the beautiful contour, although you don't have her pre-op here, but this has all been contoured beautifully. Her skin is actually lying down really nice. Okay, turn around. So this is a liposuction incision here. They're very tiny. Probably a small one over here. That's a tiny one over there. And then she'll have 2 small ones on her backside. But already you can see a remarkable difference. And in fact, she's a little bit firm here. And the reason why she's firm is because you can feel her fascia now. That's a common discovery after a liposuction. If you have a layer of fat and all of a sudden we contour that down so it's much thinner, you can feel that hard stuff, and that hard stuff is actually your fascia. So in her particular case, we're going to roll her abdominal area and her thighs towards her groin, because the groin is where the lymph nodes are. And think of the lymph nodes as the basin or the drain site that's going to take all the fluid from here and put it back into your system and get it out. So you have a small roller, and you could roll this over the skin any way you want, essentially towards your groin, like this. And anything that just squeezes the tissue, you can use some pretty good firmness, can make a big difference. Same thing for the upper thigh. Open your leg here. This is an area that typically can be more prone for some knots, because you have all the lymph nodes in this region over here. So again, you roll up towards the groin. You should do this 2 or 3 times a day, 20 or 30 minutes. If you don't have a roller, you can simply just use your hand, but these rollers really come in handy. Roll everything towards your lymph nodes, up and down, towards the lymph nodes. And as you can see, I'm pushing it pretty firmly because you have to squeeze that water out of the tissues. Okay, turn around. Now for the back side, it's a little harder to get back there with a small one-handed roller, so we might bring out the big daddy. It doesn't have to be exactly this one. This one is a high-end one. I think we picked this up at Walmart, but they're not that expensive. But again, the idea is to roll up through these crevices, right in the small of your back here, and up the flanks. And the reason why I like the two-handed roller is that the patient themselves can use the roller. Okay, so I'm going to ask you is to come on back here, grab that roller, and roll it up. There you go. So you can see it's very easy for the patient to just follow their contour, follow their curves, and just roll this really nicely. And you can even get in the back side of the upper back if you had to with this technique. And you're pressing firmly and slowly, and you're squeezing the water out of the tissue and mobilizing it. And this is how you're going to get those really nice results. These two little rollers are easily purchased for just a few bucks, and they can make a huge difference in your outcome. I encourage all my liposuction patients to start rolling about 2 weeks after the procedure, which is about the time when it feels the best. It actually may hurt a little bit in the beginning, but once you start rolling it out on a regular basis, it actually feels really, really good. So you got the big daddy and the small daddy. There are permutations of these two, but I encourage all my liposuction patients to get on the rolling bandwagon.